Hello, everybody. This should be seen as a companion mini lecture to pharmacology in general for the EMT. Though your intervention cards are incredibly important and memorizing them all the more so, it can be difficult in the beginning to digest all of this information, especially if you're not familiar with pharmacology. So I do think the end goal is to be handed blank intervention cards and fill out all of the information you see here from memory. I think it helps you both as a student and certainly as a clinician. But I want to start just discussing what I call tiny pharm, which is the bare minimum information, which is the fundamentals of essentially, as an EMT, what are the medications I have available? When should I give them? And what should I give them for? Why can't I give them even though I want to? And for adults, how do I give them and how much do I give? So we start with a discussion in albuterol and ipratropium bromide, two medications given via small volume nebulizer to help people who are having bronchospasms. Now, I use this word intentionally, bronchospasm, because if we look at our airway here, we see a trachea into a carina, then into left and right bronchus or the bronchi, going down into bronchioles, and then ultimately terminating into alveoli. So we say bronchospasm because we're referring to the bronchioles and the bronchi, but not the trachea and not the alveoli, because unlike those structures, bronchioles and bronchi, they have muscles wrapping them, which can spasm and constrict our airway, making the airway more narrow. And it's that narrowing of the airway that can cause a sound we call wheezing. Now, I use the term bronchospasm intentionally, not necessarily bronchoconstriction, because bronchoconstriction is an umbrella term that encompasses things like muscle spasms that albuterol and ipratropium bromide can fix, but it also means stuff that albuterol and atrovent won't fix, like mucus in the airway, for example. In that case, you have a narrowing airway, but albuterol and atrovent won't do anything to fix it because essentially it's not a spasm problem. It's not a muscle issue. It's a problem with having goop in the airway. Albuterol and ipratropium bromide don't fix that. Now, as an EMT, the reason for giving this is obvious with bronchospasm, but how it looks in the world might change. For example, you might arrive to find a patient complaining only of difficulty breathing, and it would require you to listen to the lung sounds and figure out what they've got going on. Because if a person has a heart attack, for example, that might present as difficulty breathing, but of course their lung sounds won't indicate bronchospasm. So, put in its simplest form, one of the easiest ways to determine that we need to administer a nebulized medication is to listen to lung sounds. And if I hear wheezing, which is the sound we give to the narrowing airways, then I should suspect that albuterol and ipratropium bromide are going to help. Now, it's worth noting that I don't just say the indication is wheezing, and that's to kind of build blocks for understanding later, but also just to mention that sometimes these medications can be given diagnostically, meaning maybe I arrive to find a patient who has difficulty breathing. I listen to their lung sounds and I would describe it as diminished. Maybe I don't hear wheezing. You shouldn't say, well, it's not wheezing. Let's not give albuterol and atrovent. Well, no. Do you suspect that they might be having bronchospasm? Do they have a history of asthma? Were they just inhaling some smoke? Was it wheezing before you got there, and now the wheezing is so bad, or the bronchospasm is so bad that it's constricted largely completely, and so you don't even hear wheezing anymore, right? Because if we whistle with our mouth, it makes a musical sound, right? And we do that by narrowing our mouth, narrowing our airway. If we close our mouth completely, in the case of a bronchospasm so bad that it occluded the airway, of course we make no sound. So I don't think it would be unreasonable to approach a patient who's having difficulty breathing, listen to the lung sounds and say, hey, I hear wheezing, let's give these medications. Or this sounds diminished, I think they might be closing up, let's give these medications. Like many of our meds or in fact, all of our meds, we're not going to administer them if the patient's allergic to them. Though I will say these are rare instances to find patients allergic to these medications, largely because they're so, I don't know that inert is the term, but they're just largely innocuous. We're going to administer them via SVN, small volume nebulizer, 2.5 for albuterol and zero point 0.5 milligrams for Atrovent. Now, a small volume nebulizer is just this little container here with a T piece that goes across the top, and a patient breathes through it. This can also obviously be attached to a mask. And you can see and hear this liquid next to his mashed up fingers, that what he did was he just upended these ampules and poured in the albuterol, 2.5 milligrams, and then he grabbed another with Atrovent and poured that in as well. And this is what we call a duoneb or a Comvivent. And then oxygen is going to be turned on at 6 liters per minute or greater. And that oxygen is going to flow up through this device, be nebulized, and then that medication is going to attach to those droplets, and then it will be breathed in this way with the patient. So, put simply, we say, oh, I can hear diminished lung sounds. I hear wheezing lung sounds. I think this is going to help you out. Are you allergic to Atrovent or albuterol? Pour in the meds, turn on the air, and then just say, hey, breathe normally through this. Breathe in and breathe out. And that gets that medication down into the lungs and causing bronchodilation of the bronchi and bronchioles. Next, we've got epinephrine, 1 to 1,000. This is for people who are experiencing anaphylaxis. And the longer I do this, the more fundamental my definition of anaphylaxis becomes. I think one of the most common misconceptions is that I think people view allergic reactions as minimal and then anaphylaxis. And I think that's mostly fine, except for it comes with an inherent assumption that anaphylaxis is going to look like death, and it doesn't always. Anaphylaxis is the word that we give to describe an allergic reaction that is having a profound systemic bodily effect. And so I've seen patients in anaphylaxis who look just fine, but of course they're not. And I've seen patients who are having a rather fundamental allergic reaction who seem like they're having the worst day of their life, and it's really just a rash, or but it's because it's causing a global rash. It's a bad experience. So we need to be careful here not to say, okay, so I should advise people who are having an allergic reaction to maybe take some children's Benadryl, but I'm going to give epi when they look really bad. And that's just not the case. So, though I think it's most commonly described anaphylaxis as 2 or more body systems with a suspicion of an allergic reaction, or hypotension with a suspicion of an allergic reaction, I'm starting to just say, look, if you suspect an allergic reaction and it's anything other than isolated urticaria or a rash, then just go ahead and give epi. Because epi is an endogenous chemical, meaning our body makes it, our body does a great job handling it, even if it were inappropriately given. So again, the longer I do this, the more I'm like, hey, look, if you think it's an allergic reaction, let's go ahead and give epi. They're certainly going to get it at the hospital because, again, largely innocuous medication. So what this looks like in practicality is I arrive to find a person with difficulty breathing or discomfort or some issue, and I, through my investigation, find that they were out hiking, that they have pain on their shoulder, their knee, their back, and they were stung or bit by something on their foot, or a new laundry detergent, or maybe they're at a restaurant and they were eating food. Or whatever the case is, their difficulty breathing, their discomfort, their itching isn't just an isolated experience. It's because I suspect that there was an allergic reaction occurring due to some antigen that they received. So we have to do a bit of an investigation here. These can sometimes be dispatched as difficulty breathing or chest pain, be a little misleading, and requires us to look a little deeper. The irony of giving a medication for allergic reaction and someone might being allergic to it, we need to follow this pattern. We have to be in this habit of every time we touch a medication, ask the patient if they're allergic to it. And then every time we touch the patient with that medication, ask if they're allergic to it. And epinephrine is no different. But much like some of these other fairly innocuous medications, usually people are allergic to the agents in the medicine that are designed to keep it stable, or perhaps the plastic in the container that they're carrying. Whatever the case, we always ask with every patient if they're allergic to it, and then don't give it if they're allergic. Now, in the case of some of these things, if somehow I knew they were allergic to them and needed it very badly, I would probably just call med control for authorization. We want to make sure that we don't harm patients, but we also want to make sure that we give them these life-saving medications. And the likelihood that a person in anaphylaxis is also allergic to epi is probably pretty outstanding. We're going to administer epi intramuscularly with a needle, and we give that at zero point 0.3 milligrams every 4 minutes. So this would be a case of, I've got a patient who, is just talking about shortness of breath. I listen to lung sounds. Maybe I hear wheezing. So I'm thinking, oh, okay, let's go ahead and give albuterol and Atrovent. And that's not crazy. But then I notice they've got a rash, or I notice that they just came in from a hike, or whatever the case. I'm starting to think, hey, I don't think this is isolated bronchospasm. This might be anaphylaxis. I'm going to go ahead and give some epi to help them out. Naloxone or Narcan. This is for respiratory depression when we suspect an opioid or opiate overdose. Now, much like we'll talk kind of with aspirin and nitro, I do want you to come in and see respiratory depression and suspect that it might be an opiate like heroin or fentanyl or Percocet. But our how we suspect those things or why we suspect those things might be relatively varied. I mean, any one of us that arrives to find a patient with a needle next to them that isn't insulin, or if somebody said, hey, I just took a bunch of heroin and then later they stopped breathing, I mean, that's a pretty clear sign or of suspicion for opioid overdose. But sometimes it's just arriving to find somebody in their home in respiratory depression, and through our investigation and looking through pertinent negatives, just discovering that we suspect this at the end of the rope, meaning I arrived to find a person who isn't breathing well, who's in respiratory depression or respiratory failure, and I listen to lung sounds. Maybe they're clear. Maybe there is nothing around them. I've run through a list of inquiry and just I can't think of what might be causing this respiratory depression. It's not crazy to give naloxone diagnostically in that case. So, you get dispatched to a man not acting right in a Kroger bathroom and arrive to find him unresponsive on the ground and not breathing, even though he doesn't have pills near him, even though you don't see any needles. I don't think it's unreasonable to give naloxone, seeing if it'll help him. Like all meds, we don't want to administer it if they're allergic. In many cases where people need Narcan, we won't be able to ask them, and so we're just going to give it under the suspicion that rare few are, and then treat with epi if they turn out to be. We're going to administer this via intranasal or intramuscular. Now, they're given, these routes are very different. Of course, with intramuscular, we're drawing up the medication and administering it with a needle into the muscle. Intranasal is different. This is what they call a MAD device, mucosal atomized something, displacer, disruptor, dispenser, I don't recall. But in any case, we'll draw up the Narcan with a syringe or using the Narcan syringe and then attach this MAD device. And this MAD device goes directly into their nair to spray up atomized medication onto their sinus cavity, right? And so you can see right here what it does to that medication. Now, a lot of this med does go into the gastric system. It's swallowed essentially, but it's designed to sit there right on your mucosal and be absorbed in that way. Intramuscularly is different. We're not going to use that little foam piece in the nose. We're going to use a needle and insert it directly into their muscle. In either case, we give 2.0 milligrams for adults every 4 minutes. And so much like epi and frankly, just like albuterol, we're just administering this, giving it some time to see if it works, and then probably giving it again in the case that it's working slightly or just needed, or that we need more to overpower the situation. With aspirin and nitro, we're giving this for cardiac chest pain or discomfort and suspected ACS. Very often, students will think it is albuterol or Atrovent for difficulty breathing and aspirin or nitro for chest pain, but it's and. We want to give both medications. If person has bronchospasm, we want to give albuterol and Atrovent if we can. And if a person has chest pain, we want to give aspirin and nitro if we can. Now, a discussion about what ACS is a little more in depth, but to put simply, aspirin causes platelets to not collect more. And so if we look at just focusing on this first picture, you can see an artery with blood flowing by and this plaque building up from atherosclerosis here. This is plaque building up. It's a narrowing artery, and that's not good. When it gets to the point that it's narrowed to the point that enough blood isn't getting through, that might be expressed as pain or discomfort, and we call that angina. Now, you won't know that. You won't know that's what you're experiencing until somebody takes a look at your arteries, because as we can see as a literal heart attack here, where plaque has narrowed the vessel and a blood clot has formed, completely occluding it, these two patients might feel the same. This person might have minimal blood flow, this person might have no blood flow, and both patients might experience weakness or pain or discomfort, and you don't know what it is, right? And so both of these patients might describe their situation as chest pain, chest discomfort, and we're going to be treating with aspirin in either case if appropriate. Now, this platelets are forming here, this clot, and aspirin is given to make sure that that clot doesn't get bigger, it doesn't break the clot down. But naturally, if platelets are kind of designed to cause blood clots and aspirin is designed to not allow that to happen, that's very bad to give to somebody who is bleeding, because they'll just bleed more. And so naturally, one of our contraindications is any sign of hemorrhage, whether that be internal or external. Now, external is easier, right? If a person is bleeding, that's a sign of hemorrhage. But we also have to make sure to ask them about their urination and bowel movements for discoloration, to suspect any type of GI tract or urinary bleeding. Now, admittedly, how this essentially will go on scene is you'll arrive to find somebody who's just saying, look, I have chest pain or I have chest tightness. You're going to want to immediately investigate their lungs, because if they have wheezing or diminished lung sounds, I'm no longer suspecting that their chest pain is a result of ACS, whether it be angina or a heart attack. So we have to do an investigation here once we experience patients with chest pain and discomfort. As always, we ask about allergies, and as far as administering, we're going to give 4 baby aspirin at 81 milligrams, or an adult aspirin that is swallowed at 324 or 325 milligrams. This is just chewed up and then swallowed, PO, meaning by mouth. Now, nitro is given just like aspirin in the sense of indication. We want to suspect ACS. Again, remembering that this is aspirin and nitro for chest discomfort and weakness, whether it be coronary artery disease, a narrowed vessel, or an occluded vessel. In any case, we want to suspect that nitro and aspirin are going to be beneficial. Unlike aspirin, we have to be more cautious about people's use of other nitrates, or just what we call low preload problems. Put simply, looking back at our vessels here, nitro causes vasodilation. So as albuterol causes bronchodilation, it causes a widening of our bronchos, our bronchioles, our bronchi. Nitro causes a widening of our arteries. And so even though nitro is not fixing this plaque issue, simply by widening the arteries themselves, we can allow more blood flow to go through in theory. Perhaps even in the case of a heart attack, causing vasodilation might help blood flow through or pass there where otherwise couldn't. Now, the issue with this is that if your blood pressure is low or below 100 and you cause widening vessels, that's going to lower blood pressure further. And a blood pressure too low means the heart won't perfuse and the patient will die. So we don't give nitro when somebody's blood pressure is below 100 or when their heart rate is below 60, because of course, this is part of our cardiac output formula. Cardiac output is heart rate times stroke volume of the heart equals essentially blood pressure. And so a heart rate that is too low will mean that they can't get enough blood back to where they need to get it in the first place either, and that's a huge problem. We talk about erectile dysfunction drugs for men and women because it works in both cases and both genders can take it. We need to make sure that they haven't had Viagra or Cialis or any ED drugs in the last 24 to 48 hours, lest they be combined with nitro and cause them a major problem of perfusion. What's really interesting is that aspirin and nitro are both for cardiac chest pain, but aspirin has a mortality reduction of about 23% according to the AHA, meaning if 100 people are gonna die of a heart attack, and I give them all aspirin, suddenly now 23 of them won't die because we gave them aspirin. Even though nitro doesn't boast such life-saving statistics, in theory, it's helpful because not only will it reduce the pain, but ideally it helps blood flow through. But again, it comes with so many more contraindications, or so many more common contraindications that we should be very careful about giving it. If you're keeping track, aspirin then can largely be given in our primary assessment because all we have to do is ask, hey, are you allergic to this and are you bleeding anywhere? Whereas nitro is not often given during our primary because we have to wait for a blood pressure and checking their literal heart rate. Though aspirin is given by mouth and chewed up, nitro is given sublingually, meaning under their tongue, to dissolve over time. And as EMTs, we're not allowed to bring this to their house and administer it. We have to check to make sure that they're prescribed it in the first place so that we assist with it. And this, again, is given every 4 minutes. Oral glucose and glucagon are both given for hypoglycemia, low blood sugar, but they have some different caveats to them. What this might look like is a patient who is altered or confused or having some type of altered mental status, in which case I want to give them, or rather check their sugar to find out if it's low. And so like in the case of glucagon, I say euglycemia, meaning normal blood sugar, and this might seem obvious. Obviously, I'm only giving this for low blood sugar. Why would you put a contraindication as euglycemia for glucagon? And that's just because with glucagon, let's say that oral glucose is us adding carbohydrates to a person's body. We're giving them sugar. Glucagon is not sugar. It's not a carbohydrate. What it does is the molecules go to your liver and extract the sugar that you've been storing so that your body can use it. So this is super dangerous to give to somebody who doesn't need it, or somebody with very low sugar stores in their liver, somebody that's emaciated or incredibly thin. So we want to be particularly careful about giving glucagon. In fact, I would say ideally we don't ever give it. We can give oral glucose. The issue is that if you are a person that's obtunded or has an altered level of consciousness, or somebody that if I give a medication by mouth, you might choke on it, well, I can't give oral glucose, and so we need to make sure they get sugar stores so that they live, in which case we'll give glucagon intramuscularly. But again, I say euglycemia because how common it is for stroke to be confused with low blood sugar. What I mean is if you get a person with altered mental status or unresponsive or unconscious, check their sugar, and if it's low, administer one of these medications as appropriate. But if their sugar is not low, then we're not doing that, even though they look like a hypoglycemia patient. As always, we're asking about allergies before administering, or at least considering allergies. The big deal here is if you're not going to choke on it, I can give oral glucose. Now, I don't really care what you remember here. One tube, 25 grams, that's fine. These are measured out in so many different ways, always in grams, not milligrams, because there's a substantial amount of medication to be given. You can give it either PO, meaning they eat it, or buccal, which means just set in their cheeks, kind of like how Narcan sets in their sinus cavity to be absorbed intranasally. This can set in your cheeks to be absorbed that way. So again, I'm okay with essentially a student knowing, oh, this person is confused. I'm checking their sugar. Oh, it's low. So let's go ahead and just give them sugar until they get better, whether that's half a tube, whole tube, 25 or 50 grams, I think are all appropriate. The only reason why I'm going to give glucagon is because they're low blood sugar and they're swallowing danger. They can't have anything by mouth called NPO, meaning I've given oral glucose and it's not working, or I want to give oral glucose but I can't, and then I'm going to give glucagon. This is given 1.0 milligrams intramuscularly. To close out our discussion, we're going to talk about oxygen delivery. And this is largely described in two different cases. A common confusion for students in the very beginning is how do I know which way to give oxygen? And I think that this can be divided most appropriately in two categories. First is in supplemental or passive oxygenation, and second, in patients who are not moving good air or hypoventilatory, we're going to go to BVM. In its simplest form, if I walk up and you look like you're having some trouble breathing, I'll probably put you on a nasal cannula. If I walk up and you're having serious trouble breathing, I'm probably going to put you on a non-rebreather. But if I walk up and you have shallow, irregular, or inadequate respirations, well, then I'm going to switch to a BVM to help you out. And these people are rarely conscious, though it is possible. So with a nasal cannula, know that our indications for oxygen, just like a non-rebreather, is dyspnea, difficulty breathing. It's also signs of respiratory distress or respiratory difficulty breathing, meaning it's not. The differentiation here is this is someone saying to me, hey, I'm having trouble breathing, in which case I'm happy to give you oxygen. This is maybe you don't say it, or regardless of whether you say it, you look like it. So this is accessory muscle use, labored breathing. Maybe it's a profoundly low pulse ox or end tidal that indicates it. But in any case, this is a person with signs of respiratory distress. And so knowing what those signs of respiratory distress are is important. Signs of heart failure is a little more complex, but falls largely in hand. These are people that appear like they're hypoperfusing. I would say that if chances are that if I've got signs of heart failure, I'm probably not putting them on a cannula. I'm probably going right to non-rebreather because these signs might be far more pronounced, symptoms as well. But in any case, I think either are technically appropriate. It's not uncommon at all to put somebody on a nasal cannula only to decide later that it's not helping as much as you want and to put them on a non-rebreather. It's also okay to walk in and put somebody on a non-rebreather, decide it's unnecessary, switch down to a nasal cannula or remove it completely. In any case, we're just looking at their pulse ox and their presentation to say, is what I'm doing enough and is it working? And so a lot of times we'll put a person on a nasal cannula, start them at 2 liters per minute, find out that it is helping somewhat, turn it up to 4, turn it up to 6, that they need more and switch to a non-rebreather. To find out later that it's helped, maybe other medications are doing well, and so we scale down from 15 on a non-rebreather to 12, and then back down to a nasal cannula. That's completely appropriate. You need to know what our FiO2 for oxygen is. Of course, atmospheric air contains 21% oxygen, and increasing the amount of oxygen molecules in the volume of air people are breathing is helpful to get more oxygen into their blood. A nasal cannula can go all the way up to 44% of the volume they're breathing is now oxygen, whereas a non-rebreather can get us awfully close to 90. And part of that is because the reservoir bag that we're filling, they're not just drawing from the blow-by oxygen of a nasal cannula, they're literally pulling from a reservoir bag that's holding pure oxygen, and that's how we get all the way up to 90%. If my patient who is on a non-rebreather declines, if they're now moving from respiratory distress to respiratory failure, they're not able to do the work, or if I just arrive to find them hypoventilatory in the first place, we're going to use a BVM. We always say slow, low, go to remind students that there are many instances in which case a BVM is appropriate, and it is so important to get clinicians to consider when a non-rebreather is wholly inappropriate and just go directly to a BVM. Like I said, many of these patients are unresponsive or unconscious at the very least, and it is possible to have patients who are conscious and BVM them, but it's very rare, and it is a full-time job. If somebody is hypoventilatory but conscious and you decide you need to ventilate them with a BVM, it can be a very stress-inducing experience, and so it requires a lot of coaching. So in general, I'd say we rarely are BVMing people who are conscious, and almost never if they're sitting up. It's very difficult to do. So with the BVM, we're still administering, even without oxygen attached to it, we're still administering oxygen. We're administering 21%. Whereas if we turn the air or oxygen on, we can get upwards of 100% because, again, it also has a reservoir. But again, the major distinction here is the hypoventilation, knowing that these are patients that are moving enough air, they just don't have enough oxygen. Whereas these are patients who it's less about the oxygen content and more simply about the mechanical ventilation of the air moving in and out. I hope this has been helpful as a companion to understanding the fundamentals of pharmacology. I want to encourage you to practice this every day on a blank sheet of paper. Write them all the medications, write all their indications, their contraindications, their adult dosing, and really familiarize yourself. After you've cut your teeth on that, when this has become simple, then we go here. And just like with Tiny Pharm, we write all of this information down and memorize it. Not only do I think it translates to good grades as a student, but I think it's fundamentals for everything that we do as EMTs. And once you master this, when you go on to AEMT or paramedic, if you have this stuff memorized, you're going to be an excellent clinician. Thanks so much for your time. Good luck to you, and take care.